So the next speaker, Dr. Tut, he will talk about bifurcation ISR nightmare. Let's see what is the nightmare. Yeah.
Yeah, thank you everyone for presentation. My case, in normal case, normal PCI, routine PCI, and this is the 75 male zero male. Patient come with us with Gaussian angina and dyspnea, and patient have hypertension, smoking, and type 2 diabetes, and he has PCI with DES 7 years ago with DES at mid-low LD and medical treatment. And on EGG so poor way progression and on echo EF about 47% and ham anterior and apical hypokinesis and EGF are about 57% ml and we do angiography. You can see here RCA quite normal, and we can see him some collateral from RCA2 LD. And for the left side, we can see total occlusion in-stent restenosis and lesion at the diagonal. Medina 111 or 011. So how good I treat for this patient? So for in-stent restenosis patient, we need to use IVI like OCT to know mechanism of the restenosis, and we can prepare for restenosis by balloon or cutting balloon or scoring balloon, and routine we can use DEF or DCB to treat DEF ISR. So we do PCI with the normal Y can go through LD. So it's the subtotal occlusion. We do the POBA with the 2.5 balloon, and then we check I first. You can see here myocardial breaching as the distal nearby distal stent. And when go to in-stent, you can see neo-arteriosclerosis, and stent may be small. Stent at proximal LD, you can see endo expansion here, small stent. And I go to nearby ostium LD. So how should I treat? As a little stand, you can see myocardial breach and patient have neo-intimal hyperplasia and undersized stand. So for this case, for in-stent restenosis, we can use DS or DCB. Before intervention, we have planned for patient in DCB for ISR, DS at LD. And for Dino, we can see a stenosis as the ostium and mid-low D1 also. And normally we need to check FFR for this. We don't know chest pain because of LD or D1. So we need to check FFR for Dino. So my plan is LD we use cutting balloon and SC balloon. Then for D1 we check FFR. If it's negative, we will stop procedure. If positive, we use BOBA, so we check again. If negative, you can use DCB. If FFR positive, we will use DES. And final, we use DCB for LAD. It's my plan. So the first we do a cutting balloon, a 275 for in-stent restenosis, and then NC30, and angio again, you can see very nice at proximal to mid-low LD. And then we check FFR for LD is negative. it's not too important because the patient have collateral, so it's enough for patient. And then we check FFR for dyno, is positive. So the next we need to bow bar, then cutting balloon, and at that time I want to do DCB for LD and dyno also. After that, I check FFR, it's still positive. So my plan is I will push stand there. I do 75 by 33 stand, do POT, and then open the LD, do the kiss post kiss post. At that time, I used the NC 2.75 to port dilation for D1. You can see here. But suddenly, when balloon go to sitting, the patient happen chest pain, pressure down, and I don't know what's happened. But normally we think about perforation, and we can see here the balloon is quite big. The first time I don't know how I use 2.75 is not easy to perforation, but you can see here. Yeah, type 3 perforation. So certainly we use a balloon to inflation at perforation. Yeah, and to what to do next? The first balloon as the dyno, so we need to use the second balloon to chain balloon, the big balloon. Both the proximal dyno to LD to easy facilitate cover stand delivery, and we maintain LD balloon inflation while advancing cover stand, and after that we inflation cover stand and pericardiocentesis. Yes, it's very important. Before we put cover stand, we need to put dilation for proximal stand. And after 10 minutes, you can see here, we still endolytic because the balloon is 2.75, 3.75. We use the cover stand 3O. CO is quite big for this vessel, but it is not total occlusion perforation. Then we need to do perforation for cover stand and do pericardiocentesis at that time. After 20 minutes, we ongoing check HCT for any intervention. But this case, we don't want to antidote for heparin, so we waiting. And still annulic after 20 minutes, we do bigger balloon, NC balloon to population with low pressure. And after that is the total occlusion perforation, and we do kissing and final DCB for LD, and this is final angiography. And after five months, we check again. At the time, we check FFI negative for LD and D1. And after month later, the patient stable, free chest pain, and EF improve. So for conclusion, yeah, we can use. I wrote OCT for ISR, no mechanism of restenosis, and DCB or DES depends on mechanism of in-stent restenosis. And FR is quite important when we choose the intervention for bifurcation, and when complications happen, we need to stay calm and manage the potential complication. Thank you.
Thank you, Doctor. Let's see the panel and for. Do you have any comment? It's really a big nightmare. Huh?
Yeah, I'm Dr. Trịnh from Vietnam. Dr. Đức have a very good case and very good results, but I don't know what is the size of diagonal when you push the stent and kissing balloon. do you have adverse for diagonal before you put stent? I know you do FFR and you decide to stent it.
Yeah, we decide PCI for dyno because that is positive after we do cutting balloon, and on IVERT I can decide use 2.75 stand. But after push stand inflation, and we do the port with 2.75, and after that we do the port dilation for dyno. I want to use 2.75, but my colleagues give me 3.75, and rupture happened. Yeah, too big balloon. Yeah.
Yeah.
So it was not the balloon that you asked for.
Yeah. Normally we inflate balloon slowly, but some my colleagues inflate too fast. I can stop. Yeah. Normally I will inflate balloon slowly, and we can see on the DS we can see too big balloon, right? I cannot stop them. Cannot stop my colleagues. Yeah, it happened.
Yeah, I think it happened, especially in the midnight during primary PCI or a prolonged procedure. Yeah.
Yeah.
Thank you.
Thank you.
Actually, I think we really want to raise the question here. So after you dilate the diagonal and the FFR there, and do you still try to do the balloon again and again before you put a stand, rather than you put a stand there? So this is my question. So if you stop the procedure by only balloon, you can increasing the size of the balloon until the FFR is become normal. So is it okay, or all of you, or you want to finish very fast with the stand? So I would like to ask the opinion about the from the panelists and also from the floor.
I'm just saying I'd try and put as little metal as possible. So I think I would have tried to go DEV personally if I could. And using the normal parameters, it doesn't recoil more than 30%, and the FFR was okay for the diagonal anyway.
Yeah. Yeah, hold on.
I have another opinion. In my hospital, I have a very good system. So before I do the complete PCI, usually I give the patient the CT first, and I have a good plan. If the diagonal very calcification, it's easy to rupture. Maybe I will try to smooth it simple. But if it is not very calcification, it only the fibrosis lesion, I will try to do Professor Quang asked. I try to balloon first. If it improve the FFR, maybe I will use DCB because the patient very old. So I think for a long time, DCB may be enough. Thank you.
Okay.
Yeah, thank you.
Thank you. So I think it is a great case, and the main reason here is because the wrong balloon size. So you cannot protect for that because it is like a human error, right? You cannot predict for that.